have one more question. Who
Mhm.
who are your patients? Of the 16 people you saw today, you mentioned there's a common thread as far as like metabolic poor health. Other than that, like what are some other commonalities you see, or did you see 16 completely different cases today?
Very different cases. I mean, I would say the biggest thing that we see is low back pain. I mean, that's the most common problem. And then after that, neck pain. But we see, people with nerve pain conditions. A complex regional pain syndrome is something that where I trained, they specialized in particular. And so that's a nerve pain condition that follows surgery and or an injury of some sort where there's a hypersensitivity of the nervous system, typically in the extremities or the hands and feet. I will see migraine patients. I do a decent amount of migraine work. In that regard, the neurologists and I have some overlap. Um, People who have had back surgery or neck surgery in the past and still have pain syndromes. I'll see joint pain, hip, knee, shoulder. And so there's really not much that we don't see. It just kind of depends on the day. And it's kind of streaky. I'll have days where I see, you know, 15 neck pain patients in a row or something like that. But it's on average, back pain is the biggest one. And it's a range of ages.
I was going to
We
ask.
do a little bit of personal injury work too. So when people have car accidents or some sort of injury, we see those folks, and so those tend to be a little on the younger side, but not always. And so we'll see people with cancer, we'll see people with sickle cell disease or other chronic conditions that are painful. So a little bit of everything.
Yeah, got it. And are these generally people that will be seeing you for the rest of their lives?
Forever's a long time. The ones that are on oral opiate therapy, the rules in this state at least dictate that we have to see them every month. Um, so probably, but I tell all my patients I'd like nothing better than to put myself out of business, if I could. And so um, like I say, forever's a long time, but yeah, most of them are going to be people that we see with some regularity for the
Got
foreseeable
it.
future.
Got it. Okay. And I know how tricky lower back pain is in particular, and this is a very generalized question. And so you could see 100 cases of low back pain, and there might be 100 different causes. You know what I mean? It's pretty tricky as far as that goes. But in general, besides changing the diet, what things would you like to see with most of your patients as far as the back pain goes? Um, Walking more, resistance training, not sitting as much. Like, are there generalized things that could help most people as far as the back pain goes?
I think there's a couple of things. I mean, first of all, my patient population struggles with physical activity because it hurts, and so it depends on the patient. Some of them, if I've got somebody in their 30s or 40s that's got, a non-traumatic low back pain, like they didn't have an injury, they didn't have any surgery in the past. It's mostly joint pain and muscle dysfunction, maybe some disc issues. Yes, we can coax them into more activity. And I typically start with the physical therapy first and then sort of expand from there, meaning, it's not feasible for me to tell my patients with back pain to get out and do a ton of walking even or resistance training right away because it's going to hurt. They're going to get discouraged. So I start with the therapy and then do that at home on a regular basis. And then, hopefully over time, we're able to branch that out. That's part of the reason I work with the nutrition element, though, because I think that a lot of these people coming from what, the standard American sort of diet, part of the reason they're having so much pain is they have a lot of inflammation. They're generally have weight issues. And so if we can get those going in the right direction, they might feel like they can do more physical activity. It might, as opposed to white knuckling it through a bunch of trying to go to the gym or something. You know, I try to get the basics right, meaning like if you smoke, knock it off, right? We have to get rid of that. If you're coming to see a doctor about stuff, whether it's me or a cardiologist or your primary and you got health conditions, you got no business drinking alcohol, period. It's a toxin. And so we can't, you know, hamstring your body by putting things that are clearly toxins in your body. And then, sort of as a segue to that, then the nutrition part comes in. Trying to get halfway decent sleep. I've been down a rabbit hole recently with circadian biology that I think is really fascinating. And I think there's a lot more to that that we've given credit for. And that I think that we haven't scratched the surface of what we understand with that. But sleep is a big deal. Everything, if you get bad sleep, everything else sort of suffers. Um, so, and then, at the bottom of that pile tends to be the activity part of things. If we get everything else right, my hope is that they can feel well enough to go out and do some activity.
Yeah, got it. Okay, awesome. As you were learning about nutrition for yourself, applying it to yourself, thinking like, what was the thinking like? Were you thinking like, okay, this is really helping me out. I feel better. I lost all this weight. I noticed that my patients need to lose weight. This diet would help them for the weight loss. Or was it occurring to you really early on that this diet really could address pain? Because I think that's really surprising to a lot of people.
It was sort of, it wasn't right away that I recognized that. I didn't think that right away. It was more as it happened to me, as it happened to some of my patients or my coworkers. I had a woman I worked with who was on the younger side. She was a heavier person. She had had a back surgery in the past, and by the end of the shift at work, she was hobbling around because her knees and her ankles were killing her and her hips. I got her kind of going in this direction with respect to nutrition, the way I talk about it, and even before she lost 5 pounds, it wasn't much. It was only a few pounds that she had really lost, but she didn't have that joint issue anymore, and so it was a joint pain improvement that was independent of weight changes, and that's what got me thinking about this. Like, wait a minute, there's something else going on here because I had another woman who she was very she was thin. She was in good shape, relatively speaking, but she was eating not the best. She was convinced she was going to need a hip replacement, and we got her eating this way. And she came back like 3 or 4 months later. She's like, my hip doesn't hurt anymore, right? And it wasn't that she lost weight; she was already thin to begin with. But that mirrors what you see from the orthopedic folks, Dr. Fetke, Dr. Baker. Some of these guys that have said these folks that thought they might need a knee replacement don't need it anymore. And so it was a little bit of that. It was me trying to give these patients a direction, as opposed to eat less and move more. Because again, like I just said, they can't move more. Not really. Not enough to move the needle on weight loss in most cases. And when you look at the evidence for physical activity for weight loss, it's really not very good. Like weight management just by purely moving more doesn't wind up panning out. Or you've got to be really you'd be so dedicated to it that it's not feasible
Yeah.
for my patients. So kind of all those things together, and then the more I looked into it, if you think about like a ketogenic approach, which I don't think is mandatory, like as like a strict, like you have to be in ketosis all the time, right? Like I don't like being dogmatic about that, but if you look at what that did for epilepsy patients, and still does for epilepsy patients, um, most of the nerve pain medicines or migraine medications that we use are seizure medications, and so you have an intervention, a nutritional intervention that treats seizures and does so very effectively, and then you're using seizure medications to treat nerve pain. So why wouldn't there be some benefit to nerve function in some fashion, from a ketogenic approach? And that's what we see. And as an extension of that, you've got the work that Chris Palmer's done, Dr. Chris Palmer, in psychiatry, and so and as well as Dr. Georgia Ede, seeing benefits in terms of mood disorders, bipolar, schizophrenia, depression, you name it. And so, from a pain perspective, when it comes to that, mood and pain are so intertwined, it's hard to tease them apart. And when one improves or worsens, the other one tends to follow.